Hello and welcome to our virtual symposium, Multiple Sclerosis Update, Clinical, Economic, and Patient-Centric Strategies for Specialty Pharmacy Professionals. Thank you for joining us today. We are joined today by our moderator, Michael Zeglinski, Senior Vice President and CEO at Optum Specialty and Infusion Pharmacies, along with our speakers, Dr. Mitzi Joy Williams, who is the Assistant Professor of Medicine, Clinical Neurology at the Morehouse School of Medicine. And rounding out our faculty is Alexis Crispino, Director of Education and Healthcare Relations from the Multiple Sclerosis Association of America. And it's my pleasure at this time to pass the microphone over to our moderator, Mr. Zeglinski, for his opening remarks. And Michael, the audience is all yours.
Hello, and again, my name is Michael Zeglinski, and I'd like to welcome you to today's virtual symposium. We're pleased to be able to provide you with what we hope will be an informative and meaningful continuing education activity. Today's program is jointly provided by Medical Education Resources and Impact Education, LLC, and is designated for 1.5 contact hours of continuing education credit. This activity is supported by independent educational grants from Sanofi Genzyme and Bristol Myers Squibb, and we would like to thank them for their support. We would also like to thank Assembia Specialty Pharmacy Summit for sponsoring this virtual learning experience. Assembia is committed to helping meet your continuing education needs during these challenging times. The agenda for today's program is as follows. As you see on the screen, we will start with Dr. Williams, followed by myself, followed by Alexis, and then we will have a question and answer session as noted at the end with some key takeaways and closing comments. The learning objectives for today are on the slide as follows. To discuss where current and emerging therapies fit into the MS management algorithm, review the potential impact of and value of real-world evidence to inform clinical decision-making in MS, explore how to integrate electronic health technology into MS care management, and employ treatment optimization approaches to balance costs with improved outcomes in MS management. I would now like to introduce Dr. Mitzi Joy Williams, who will present Assessing the Clinical Benefits of Current and Emerging MS Therapies in a Specialty Pharmacy Setting. Dr. Williams is the founder and CEO of Joy Life Wellness Group, LLC. Welcome, Dr. Williams.
Thank you so much, and it is my absolute pleasure to be here with these esteemed panelists and to discuss a little bit about management of multiple sclerosis. So we'll get right into it. Our objectives for this portion of the discussion are to talk about current and emerging therapies, where they fit into the treatment and management algorithms for neurologists and treating clinicians, and also to talk about the potential impact of, just one second, I apologize, we're having a little bit of a technical difficulty here. Okay, and talk about the potential impact of real-world evidence to help us inform our clinical decision-making. So let's just start the discussion by talking a little bit about our understanding of what multiple sclerosis is. So it is considered an autoimmune disease, meaning the immune system attacks a certain part of the body, and it is also chronic and progressive. Each autoimmune disease has a different target within the body, and the target with multiple sclerosis is the myelin, or the coating of the nerves in the central nervous system. The central nervous system includes the nerves to the eye, the optic nerves, the brain, and the spinal cord. And so what happens is when that demyelination occurs, it sets into motion several processes that result in the disability that we see related to the disease. So it's not just that there's demyelination, but we also begin to see neurodegeneration or dying away of the nerves in those areas that have been affected over time. And this is what results in some of the immediate, but also the long-term disability that we see associated with MS. Unfortunately, we do not know the primary etiology of MS, but we do know that there are several factors that lead to the increased risk for one person developing the disease. We know that genetics plays a part. but certainly genetics is not the whole story, because twin studies showed that identical twins only have a 25% chance of having MS if the other one has MS. We also know that there may be some environmental factors that play a part, and there also are many that are looking into different things such as viruses and bacteria and the role that they may play in increasing the risk for multiple sclerosis. How about epidemiology? So this is a great slide that tells how we now have a better estimate of the actual number of people in the United States that have multiple sclerosis. So up until last year, when a study was published, sponsored by the Multiple Sclerosis, the National MS Society, we thought that 400,000 people in the U.S. live with MS. But last year, once the study was completed, we realized that it was more than double what we had been reporting before then. It's most common in people who are aged 20 to 40 is where most people are diagnosed. It is the most common cause of neurologic disability in people between the ages of 18 and 60 years old. It's more common in women, up to 3 times more common in women than men. And then the last statistic is very compelling, that it's estimated to be over to 6.8 to 11.9, almost $12 billion in annual costs related to the care and treatment of MS. What about symptoms? So people with MS can exhibit a variety of different symptoms, and there are symptoms that we call physical or visible symptoms, but there are also symptoms that we call non-physical or invisible symptoms. So physical symptoms are ones that are very easy for people to kind of grasp their minds around as a cause of disability. So for instance, visual disturbance, oftentimes people will present with a problem called optic neuritis, where they may lose vision in one eye or the other eye. Also, people will have spasticity or cramps in different parts of their body. They may have problems with balance and walking, or weakness and numbness and tingling. So those are physical symptoms, or what we call visible symptoms. The non-visible symptoms or non-physical symptoms are ones that can cause significant disability and often can actually lead to people leaving the workforce. And so they're also very important to pay attention to. So one of them is cognitive impairment. One that is not listed here is fatigue. Fatigue, which is a huge symptom and often a common cause of people leaving the workforce, and it's actually an overwhelming fatigue that's very different from, say, for instance, my fatigue after dealing with my 3- and 6-year-old all day. So it's a very different type of fatigue. We also see a lot of mood disorders and what we call pseudobulbar affect, which is an inappropriate emotional response to certain stimuli. So here's the first question. What is the lowest EDSS, that's a disability scale, what is the lowest EDSS scale score that indicates severe disability with multiple sclerosis? So we'll give you a second to answer there. Okay, I see people are still answering. Okay, I think, let's see, people are still answering. We'll give you a couple more seconds. Okay, a couple more answers. Okay, so we'll end the poll there. Okay, and let's see what we've got. Okay. All right, so we see from the poll here that about, let's see, the highest percentage of folks, so we have about 24% said 4. Okay. All right, and let's see what the answer was. The correct answer was 4. So the majority of people have the correct answer, which is 4. So that's the lowest number that's considered pretty significant disability that certainly can interfere with someone's daily activities. The number that's often in many people's mind is a 6, and the 6 is where you begin to have difficulty and need assistance with walking, meaning a patient would need either a cane or a walker or some type of device to assist them in walking. But we can see that this is the disability scale. So we go from normal, which is here at the top on the left-hand side, and then 9 is confined to a bed. So certainly this is the best scale that we have to measure disability, but certainly we realize that this does not include many of those invisible symptoms very well and is very heavily weighted on walking. Right, so let's talk a little bit more about the course of disease. So how do we determine if disease is getting worse, if it's progressive, or what are kind of the stages of MS? So there are certain categories that we look at. The first category is preclinical. So this would be more of what we call radiographically isolated syndrome, or in some cases we won't even know that disease activity is going on at this time. But oftentimes by the time someone is diagnosed or has symptoms, there are lesions that have been developing over time that just have not necessarily caused a clinical symptom. And then once they hit that period where they have a clinical symptom, let's say an optic neuritis or vision loss, then they would have a diagnosis of CIS, or clinically isolated syndrome, and we'll go into that in a little bit more detail. And then we go to relapsing remitting, where someone has recurrent symptoms, either clinical symptoms or symptoms on MRI that happen over time. So the clinical course is there at the top. Okay. All right. And then what we see if we go to the bottom is we see the MRI course. So we can see over time that the MRI, those arrows, are pretty active in the first phase, the preclinical phase, and the relapsing remitting phase. But when we get over into the right side of the graph, which popped up with the last part, we can see that there's a little less MRI activity. But we do begin to see disability rise. So I know this is a complicated graph, but it's got some really good information on it. So we talked about kind of the clinical course going at the top. The second line, the blue line, is brain volume. So as we age, our brains shrink over time. And I'm sorry to say it, gentlemen, but your brains shrink a little bit faster than the ladies. But it is normal for our brain volume to decrease over time. However, that is accelerated with multiple sclerosis. So we can see in the beginning stages, the brain volume is pretty preserved, but towards the end of that relapsing remitting on over into that third area or section, the secondary progressive, we see brain volume begins to decrease. And in turn, we see with clinical activity, we see relapses or disease symptoms in the beginning phase. In the middle part, we see that those are pretty active, but over time, as we get more into progressive disease, we see less of those clinical relapses or symptoms. And also lesion load or disease burden or lesions on MRI increase over time. And the question becomes, when we talk about kind of the early stages of MS, CIS, and relapsing remitting MS, many of us, especially in the MS specialty community, believe that this is the best opportunity, and it's also, there have also been several studies to the same vein, saying that this is really the opportunity for us to really have an impact on disease progression. And the earlier we start with treatment, and some suggest with more aggressive treatment, the more impact we may have in trying to decrease disability over time. So now let's take a step back and talk a little bit about these subtypes, which I alluded to in the last slide. So radiographically isolated syndrome and clinically isolated syndrome, these are in the same kind of box, but they're not exactly the same thing. So radiographically isolated syndrome is, let's say, for instance, someone has a car accident and they go to the hospital and they have an MRI to, assess, or they have a CT scan or some imaging to assess to see if they're having issues. Or they may have a headache and their physician may order an MRI. And then when that MRI is ordered, we see lesions that look very typical of MS, but they've not had any clinical symptoms that are indicative of MS. That will be what we classify as radiographically or radiologically isolated syndrome. And in those cases, from the studies that we have available, there are suggestions that probably about a third of those people would go on to develop MS. So many of my colleagues and I would not likely treat people in that category who have not had clinical symptoms, because 2/3 of them may not have any more symptoms typical of MS. And then we get into clinically isolated syndrome, which is where a person has lesions on their MRI that look typical of MS, and they have at least one clinical symptom. With those folks, probably about 85% of them may go on to have further symptoms of multiple sclerosis. So most cases of CIS we actually treat with disease-modifying therapies. Then there's relapsing remitting MS, where someone has a symptom that comes on, lasts for a certain period of time, and then they may have another symptom. We can see from this first graph that people develop disability over time because they don't necessarily go back to normal after each clinical episode. And so that's how we see disability that accumulates over time. Then there's secondary progressive MS, where someone starts out with that relapsing remitting course, but over time, generally somewhere between 10 to 20 years, they may just have more of a progression and an occasional relapse during the course of disease. And then finally, there's primary progressive MS, where people just generally have symptoms that come on and accumulate, and they really don't have very many lesions. They really don't have very many relapses, and we don't see a lot of new lesions on MRI. And this is a graph just showing the frequency of those subtypes. So the majority of folks start out with relapsing remitting MS, about 85%, and then we see about 15% of folks start out with primary progressive. That was the one where they just continue to get worse and very rarely have relapses. And then out of the 85% with relapsing or remitting MS, we believe that about 50% of those will go on to develop or transition into secondary progressive MS. So they start out with the relapsing remitting course, but then over time, they just continue to develop disability. And I'll pause right here for a second just to make sure that we understand that when we say remission with MS, it does not mean absence of disease activity. So a remission can just be a period of stability. If someone has a relapse and let's say they lose vision in their eye and they regain 85%, if they retain or stay at that 85%, for 6 months to a year or 3 years or 5 years, that would be considered a remission. So it does not mean that the symptoms completely go away, which again increases the urgency of making sure that we're treating people effectively to try to prevent disability. The components of an MS diagnosis there's several things that we do. So certainly the clinical history makes a big difference, as well as exam findings that show us areas of previous neurologic insult. Also, MRIs of the brain are very helpful in helping us to look for patterns that are typical of multiple sclerosis. There are laboratory tests that we do to rule out things that mimic MS. MS is really what we call a diagnosis of exclusion. So we try to rule out other causes for those symptoms. So if someone has numbness and tingling, it could be from a vitamin deficiency, or if they have other symptoms, it may be related to a rheumatologic disease. So we want to make sure that we're looking for other reasonable causes of symptoms. Also, we do CSF studies or spinal tap in some instances, and there are certain things that we look for that indicate that the immune system is overactive. And then also in some cases, we may need certain neurophysiology tests, such as evoked potentials, which I often do in some of my patients, because they could show, for instance, visual evoked potentials could show very subtle damage to the optic nerves or the nerves to the eye, even if a person has not necessarily lost vision in one eye. So we look at it as building a case for or against multiple sclerosis, and our tests help us to understand if we feel like that person has demyelinating disease. So what are some of the predictors of disability? We're always trying to look for prognostic factors or things that can maybe indicate to us that someone may have a more difficult course of disease or that someone may have a more aggressive form of disease to help inform treatment. So there are clinical predictors of disability. Certainly the longer someone has disease, the more time they have to accumulate disability. If someone has a higher relapse rate, those relapses are those clinical symptoms that come on and either go away or stabilize. Certainly, if someone has a higher relapse rate, remember from that last graph that they may not come back to normal. So the more relapses they have, the more chance they have to have disability left over from each episode. Also, if they have more frequent early relapses and poor recovery from relapses. So those are all poor prognostic factors. Also with imaging, spinal cord lesions can cause a significant amount of damage, diffuse abnormalities in the spinal cord, as well as atrophy or shrinkage of the brain and lesions further out on the outside of the brain. The spinal cord is what I call expensive real estate, meaning there's a very large amount of function packed into a very small space. A person can have multiple lesions in their brain, but because there's so many other different connections, they may be able to continue to function fairly normally until they have a brain lesion in a sensitive area. However, one very small lesion in the spinal cord could cause significant disability, such as loss of use of a limb or significant numbness and tingling and pain in a limb. So we definitely tend to be a little bit more aggressive with therapy if we see spinal cord lesions. And then finally, in terms of the patient, prognostic factors, if they have a younger age of onset, certainly the men tend to have more disability than women. And then if you look at ethnicity, African Americans and Hispanics may have higher or more severe disease course as compared to Caucasians. So what are our goals in treatment? So the same things that we look at in real life are many of the things that we look at in our clinical trials to determine if a medication is effective or not, or what our goals are in terms of treatment. So we certainly want to affect the patient, and we want to affect the MRIs. So we want to affect the patient in terms of reducing or decreasing relapses. We also want to slow progression of disease. Even though we can't stop it, we certainly want to slow it over time. And the overall goal, as we're moving closer and getting more highly effective therapies, is to try to end relapses altogether, and we would love to be able to stop progression. In terms of MRI, we certainly want to reduce the burden of disease, because even if lesions do not cause a person's symptoms at the time they develop, over time, as the nerves begin to degenerate and die away, we can see increase in symptoms related to those old areas because the nerves may not be functioning as well. And so our goal, our ultimate goal, is to try to stop MRI progression as well. And then another important measure that we're looking at more closely is cognitive function and quality of life. And we definitely want to improve quality of life for our patients with these therapies. So our ultimate goal is to halt disease activity, reduce disability, and improve quality of life. So when we look at evolving clinical outcome measures with MS, there are certain things that we're looking for that can help us to assess disability progression. So we certainly look at certain measurements in our trials, such as the EDSS, which is our disability scale. However, we discussed that it's very heavily weighted on walking, so it may miss some of the other finer issues that may cause significant disability. The 25-foot time walk can tell us a little bit about walking. The 9-hole peg test can tell us some about coordination and cognition. And then we have the DMT, which is a cognitive measure. The way we assess disease activity is looking at relapses, MRI activity, and atrophy. And so these are some of the outcomes that we try to look at. And a newer goal that we've looked at is called NEDA, or no evidence of disease activity. So our goal with many of our studies is to look at the percentage of folks who have no evidence of disease progression and disease activity. So why is early treatment important? So certainly, we definitely want people to start treatment as early as possible. You know, that could be within 12 months of someone having an MRI or having their symptom onset. For some people, it takes them a little bit longer to get diagnosed, but we certainly want to diagnose and treat as early as possible. Certainly, when I discuss treatment options with my patients, we recognize that, you know, our treatments are a little bit more difficult to obtain, so we can't necessarily just write a prescription and get someone the treatment, but certainly we want to try to start within a reasonable period of time. So in terms of, again, kind of looking at the course of disease, early on in disease is where we really have our opportunity to make an impact on the inflammation, the demyelination. So you can see here the clinical disability, the relapses are very active in this first part of this graph. There's a lot of inflammation, there's a lot of damage to the axons or the nerve fibers, and we also see a lot of relapses. So we really want to impact in this early area to try to prevent the disability curve over time, because we see as we go towards the middle, we see more inflammation, but less than we saw in the beginning. And the reason inflammation is important is because most of our treatments target inflammation or decrease inflammation. And so that's what they're best at doing. So we want to try to impact that. So in the middle graph, we see more inflammation, but we still see demyelination persisting. And then once we get to progressive disease, all the way at the end, we see that there is less inflammation, but we see there's certainly a lot of axonal loss or damage to the nerves. And then we also see disease progression. So there's less of an impact that we can make on the back end, but in the first part of this graph, we can actually make a significant impact on disease course and disability. Now, this is another graph looking at early treatment with disease-modifying therapy and how it's associated with reduced risk of disability. So what we can see is that the impact of early treatment, we can see that there are about 2,500 patients who started treatment within 6 months, and they had about a 36% lower risk of disability. And so after they were followed up over time, they were followed up for about 18 months. So we can see that if we treat people very early within those first 6 months, there's actually a 36% less chance of them having significant long-term disability. Also, we see that early DMT treatment is associated with later conversion to secondary progressive MS. So again, this is important because once someone develops secondary progressive MS, we have less of an opportunity to actually impact disease course. So we want to make sure that we try to treat them early to delay that progression so that they can continue to function in their regular activities as well as employment and things of that nature. And so this graph is just showing some of the follow-up that people converted to SPMS later, and there was follow-up at 7.6 years, 4.5 years, 4.9, and 7.4. All right. This is another very interesting table that shows how the treatment landscape for MS continues to expand over time. So when I first started treating MS, we were really in the injection phase, and so all we had were injectable therapies and one infusion therapy, and we can see that the field has really exploded over time. And since about 2010, there's been nearly one new treatment every year, and sometimes 2 or 3 treatments approved per year. So there's really been an amazing explosion in the research and treatment of MS, and it's really evolved so that we can significantly decrease the disability for our patients. Also, this is a graph looking at the indications for our FDA-approved treatments. So all of them are approved for relapsing remitting MS. There are several, there are interferons or injections primarily, and then several of our oral therapies are approved for clinically isolated syndrome. There is only one therapy approved for primary progressive MS, and then we now have 4 therapies approved for secondary progressive MS, but the one at the top, mitoxantrone, has really fallen out of favor because of potential cardiac side effects as well as secondary leukemia. So we don't really use that one very much anymore in practice. Also, if we look at the clinical benefit of widely used DMTs, we can see some of the numbers related to reduction of relapses, and we can see as our medications, as we kind of go down the list and we have newer medications, we can see that certainly some of those numbers are higher in terms of the percentage of decrease in annual relapse rate, and you can see the ones that are in black or highlighted in black are some of the higher numbers. You know, it's very important and to recognize that our trials were conducted very differently in the earlier phases than in some of the later stage medications that were approved, because many of our earlier drugs were used on people with more aggressive and progressive disease. So when interferons came out, people who were in the studies had disease for some time. However, as more treatments became available, many of our newer studies had patients who it may have been their first therapy or patients who had a very short duration of disease. So we have to be careful about comparing just these numbers, but certainly we can see that as we have more effective therapies, we're seeing that these numbers are better in terms of reducing relapse rate. With the injectable disease-modifying therapies in terms of safety and monitoring, certainly these are definitely some of our safer options. The most common side effects are things like injection site reactions. For some, there are flu-like symptoms, but overall patients, we don't have significant infections or other immune-compromised symptoms that we have seen in some of our previous therapies. So with our intravenous options, there are certainly some concerns about safety and side effects. So we'll start with natalizumab. The main side effect that we're concerned about is PML, which is an opportunistic infection that can cause significant disability or death in some cases. Also with alemtuzumab, the most common side effects are infusion reactions, and people can also have autoimmune problems. So they may have autoimmune thyroid disease, ITP, which is an autoimmune platelet disorder, as well as there's a very low percentage, 0.2%, that developed an autoimmune kidney problem. And this one does involve pretty extensive monitoring every month for several years after the medication is taken. And there's ocrelizumab, which is a once every 6-month medication that can be associated with infusion reactions, as well as reactivation of hepatitis and some opportunistic infections. Our oral DMTs, I'm not going to go into depth about each and every one in terms of safety issues, but our S1P modulators, we just had one approved in the past couple of months, actually since the COVID pandemic, ozanimod, but we have 3 in that class. The common side effects are lymphopenia or decreased lymphocyte count, as well as elevation of liver function tests. Some of them require cardiac monitoring with the first dose, as well as eye examinations because there's a risk for macular edema. With teriflunomide, there could be some hair thinning and increased liver enzymes. With dimethyl fumarate, we see some flushing and GI distress, as well as leukopenia. And then with cladribine, we see upper respiratory infections, and there's a potential risk for malignancy. So one of the things to keep in mind is that the disease-modifying therapies are not interchangeable. So if you look back at those graphs, there are very few that we have that are in a class. So we only have two classes where there's more than one therapy. So the S1P modulators as well as the interferons. Aside from that, each therapy has a different mechanism of action, different benefit risk profile, different route of administration in terms of safety. And so MS is a very individualized and personalized treatment. We have very personalized treatment plans for our patients because of this. And there are very few head-to-head trials that directly compare the DMTs, especially oral and intravenous. So many of our newer trials do compare to our injection therapies, but there are very few that compare our highly effective therapies. So it's very important to recognize that these are very different, and there's no one treatment plan or one size fits all for people living with MS. So what do we consider when making that initial treatment decision? Certainly we consider the disease activity, if it's very active, if they're having lots of relapses, if they are having severe lesions on MRI. We also have to look at tolerability. We have to look at the safety. Do they have other comorbidities that may affect monitoring? Are they able to participate in some of the monitoring, especially if it's frequent? And also if there are drug-drug interactions, we have to look at that. We have to look at what the patient could be adherent to, and also look at personal factors such as family planning. Many of our patients are very young. Remember, we said 20 to 40 years old. So we have to take into effect which ones may be teratogenic. We have to look at if they have busy work and travel schedules, and kind of how the disease-modifying therapy will fit into their lifestyle. So the time to sustain accumulation of disability by initial treatment strategy, this was a paper from JAMA from 2019. And basically, there are a lot of us that are trying to figure out, are highly effective intensive treatment versus escalation therapy is the best way to go. And I would say the jury is still out where this is concerned. From this paper, it looked like that long-term outcomes were a little bit more favorable for early intensive therapy. I think that certainly one of the difficulties is that MS is a lifelong disease. So what we see, at even 10 or 15 years of outcomes may not be the same as what we see at 30 or 40 years of disease activity. But certainly many of us in the MS specialty field are favoring starting early aggressive treatment to try to delay disability, and this paper would support that. So here's another question, another poll question. Which of the following DMTs are considered to be interchangeable? And so I'll give you a few seconds to do that polling question. Okay. All righty. Okay. Okay, we're still voting a little bit. Okay, so I'll end the poll there. Okay, so I guess I was a little bit too strong in my thought that, so certainly none of our medicines are exactly interchangeable, but the correct answer was ozanimod and siponimod because they are in the same class. So they're not the exact same drug, but they are in the same class. They're one of the two, classes of drugs that we have, where there's more than one drug in that class. Okay. All right, so what are other factors that are influencing the decision to switch disease-modifying therapy? And I'll go through this pretty quickly because I believe I'm at the end of my time. So when we talk about first-line therapies and switching to another first-line therapy, the reason we would do that would be because of tolerability. So, if there was suboptimal efficacy, we would not want to do a lateral switch. We would definitely want to escalate. So if we're going from a first line to second line, certainly if there was suboptimal disease response, if someone were having, let's say, relapses or had new lesions on MRI, And then in some cases, a second-line switch may be for relapsing remitting patients transitioning to secondary progressive. And so if a person is worsening, that may also be a reason to switch. If we're going from second line to third line or higher, it's definitely because of increased disease activity. So more relapses. Also, if there are safety issues, for instance, with some patients on natalizumab, if they have an increased risk for PML, because there is an antibody test that we can do to help assess risk. If that antibody test goes from negative to positive, that may be a reason to switch therapy because of safety issues. And then in very rare cases, someone may switch from a second line to a first line DMT, and it may be because of tolerability issues. So patients prefer DMTs that have mild side effects and delay disability progression. And this is an interesting graph kind of showing some of the patient preference. So they definitely want mild side effects, but also effective therapy. And so many of our more effective disease-modifying therapies fit into that category. Also, the monthly the monthly out-of-pocket cost definitely influences the patient's decision for or perceptions of DMT. So certainly this is extremely important, especially in this economy where many people have lost their jobs, et cetera, due to the pandemic. Out-of-pocket costs are going to play a large part in some of their choices. And then lastly, we want to make sure that we're using real-world evidence to treat MS. As I said, there are not a lot of clinical trials that compare our higher efficacy drugs, but there are many registries here in the U.S. and across the world that can help kind of, in a sense, compare some of the outcomes and fill some of those gaps that we don't have in our clinical trials. And so the reason that this type of data is important is because randomized controlled trials definitely describe patients. We can see what an inadequate response to therapy is, but certainly real-world evidence can help us understand the effectiveness of early treatment and how to optimize treatment, as well as provide us some insight on some of those questions that we can't answer in terms of, let's say, side effects or comorbidities, things that may have been excluded from our clinical trial data. And so in summary, we talked about how MS is a chronic progressive autoimmune disease that is very variable between patients, that our disease-modifying therapies should definitely be initiated early, preferably within 12 months of the onset of symptoms. And then certainly there are multiple safe and effective DMTs that are available, and then there are also many that are still in development. And there's one that was approved this year, and there's one more that we expect to be approved by the end of the summer. Clinical trials certainly give us a great deal of data, but we definitely need real-world evidence to compare some of those higher effective therapies, as well as answer some of those clinical questions that we can't glean information from in our clinical trials. Perfect. And with that, I will hand it back over to Michael. Thank you so much for your time and attention.
Thank you for the excellent presentation, Dr. Williams. Next, I will present specialty pharmacy management services for optimal outcomes in MS. So the learning objectives, as you see on the screen, we'll be talking about how to optimize treatment and balance costs, how to use electronic health technology, understanding the costs, building upon what Dr. Williams already talked about, understanding the challenges in managing people who have MS, and also talk about the importance of pathways in improving the outcomes. So we have a polling question here. So this is a personal question for you all. Which of the following best describes your area of greatest educational need with regard to the MS? Obviously, no answer is wrong, and this is specifically reflecting everybody's personal experience and educational needs. Give another couple seconds here for people to complete the poll. And we're all winding down now. All right, let's reveal the results to everybody. And what we see is about 25% of you say that complex treatment decisions and prolonged treatment duration is one of the greatest educational needs you have, followed by, looks like a tie for expanding treatment armamentarium, as well as limited head-to-head and cost efficacy data. So let's move on and talk further about what we can address as specialty pharmacy and working with people with MS. First and foremost, as we know, MS is a costly disease. This slide shows some of the costs from the DMT perspective versus non-DMT. Certainly, as you look at some of the agents that are out on the market today and available, the DMT costs are significantly more than $28,000. This data was taken from several years ago, and we know that the annual cost for some DMTs range between $60,000 all the way up to about $100,000. So when you look at people with MS, not everybody is on a DMT, and some people have different medical costs associated or affiliated with their disease state. But in general, as this gets updated over the next several years and we look at the costs for the pharmacy costs, the DMT costs versus the medical costs, we expect to see that the pharmacy costs will even more significantly outweigh any of the medical costs that exist. When we look at costs, as expected, as the disability progresses, we certainly see that the costs per year for patients certainly is going up and would be expected to go up, especially if they are started on DMTs and if they begin to have other issues that result in hospitalizations or other healthcare needs in order to manage their conditions. One thing that we have seen is that when you look at the drug benefit, what we are trying to balance is how do we provide the best cost for the best care. And the three things that we look at specifically are assuring that people are on the right drug, and we look as well if they are having their medications infused, that they're getting the right site of care, and that the cost is factored in as well. As I said before, the range of costs for the DMTs can go anywhere from $50,000 to $60,000 all the way up to $100,000. So what is the right cost that will be the right outcome for this patient? Well, as Dr. Williams described, based upon the diagnosis, the drugs need to be selected that will be most effective for that patient. And at times, patients may need to be moved from one drug to another in order to make sure that they are receiving the efficacy as expected. What we also see as an opportunity to manage costs is to assure that the patient's benefit, whether that is the pharmacy or the medical side, is taken into account when the site of care is considered. Some medications may require a controlled setting in order to administer them to assure that safety is in place, but some medications may also be able to be administered at the home or in a physician's office. So making sure that we understand the patient's benefits, the costs of receiving those medications at a hospital versus a doctor's office versus an infusion clinic or at home is critical in order to balance cost with the drug and the right site of care. So what is the right drug for somebody who has MS? Well, the treatment definitely has to be individualized. We need to make sure that we understand what disease diagnosis the patient has. We make sure that we understand as well that we're not going to cure the disease with these therapies. And we also want to be sure that for the patient that we optimize their ability to administer the medication. So oral obviously is one of the easiest ways for people to administer medication, but we know that all of these different routes, oral, IV, sub-Q, and intramuscular, are available. Patients may have caregivers. They may be able to administer the drugs via sub-Q themselves, for instance, but they may not. And we have to understand that based upon their diagnosis and based upon their ability physically themselves or with a caregiver, that those have to be taken into consideration when selecting the right drug. When we look at utilization then from the benefit perspective, Also, patients have different insurances, different coverages. So understanding the formulary for their medications, which drugs are covered, which are not, what tier they are on, what their co-pays might be. Some drugs may have prior auth or step edits that are included, and understanding as well if there's cost sharing. If somebody has a high deductible health plan and they have a high cost at the beginning of the year, they very well may be seeing that their cost is very high at the first or second month of the year, and understanding the patient's benefit is key, because what we also see is one of the primary reasons for non-adherence, which we'll talk about in a little bit. One of the primary reasons for non-adherence is not being able to afford the medication. So that has to be taken into account as well when we look at utilization. As I mentioned before, site of care is also very important. It can impact cost if we are having the drugs administered at a high cost site of care versus one of the lowest cost sites of care may be the patient's home. Understanding where the patient is in their disease progression and their ability to receive medications in the different forms that are available and the type of support that they have around them. So if somebody is still at home and able to provide them their own care themselves, that's going to vary dramatically between what happens if they progress to a skilled nursing facility and somebody is administering the medication for them. So as I said, many of these issues have to be taken into account, and care becomes very complicated as patients progress through their disease process. When we look at patient-centered care, what we want to look at is, if possible, home infusion as an option, especially as we have found during this pandemic. Many patients or many hospitals are not able to have their infusions within a hospital setting because of what is happening with the pandemic. But even before the pandemic, having the ability to receive an infusion at home is welcome by many people. It allows them to live as much as possible a normal life. It also helps to reduce other types of impacts there might be, especially having to travel, having to sit and go through an infusion, and then having to find transportation back home. So understanding a patient's socioeconomic perspective and what is an option for them is critical in selecting whether a patient would receive their infusion at a home setting or at some other type of setting out in the community. So when we look at managing MS, even though we have all of the drugs that Dr. Williams showed us earlier, it still is a challenge to manage MS. We have physicians that have a lot of options now as far as administering the medications and prescribing them, but we also have challenges with the costs of these therapies as they have grown ever more expensive over the years. Taking those things into consideration, other comorbidities a patient might have, reactions that people might have had previously to medications, or even looking at efficacy. Are these drugs working for people? Are they helping to slow the progression of their disease? Those are all things that are difficult to do and must be very individualized with patients in order to determine if the medications are working effectively. One of the ways that are very effective and that could certainly help is, how do we use digital tools to better monitor and better report out on what is going on with a patient as far as their disease state and any progression that they're seeing. By getting information from patients and having that reported on a regular basis, we are able to have much more data available to us longitudinally that we can monitor and we can use to take into account what is happening with patients over time. Because this is a progressive disease for many people, understanding over the course of several months what is happening with a patient can help make an intervention occur much sooner than if they are simply going in and being seen maybe every 6 months or once a year, and the progression was occurring, but it might not have been reported or seen by the patient as something that was a reportable event. So digital tools can certainly help us with this. And as well, because many of us are at home now and many of us are doing this this particular CE virtually, we all understand that these tools in people's homes and having them mobile and able to use Wi-Fi, internet, cellular signals, the ability for us to get this information is even better now than it was just a few years ago. We're able to not only have data streaming to us to monitor, but also from the healthcare professional perspective, a lot of visits can now be done via telemedicine. They don't need to be face-to-face traveling to the office. And that might be very difficult for some patients who have progressed in their illness to actually be mobile and get out to a physician or to a hospital or wherever they may need to be seen. So we've seen some great advances come about because of the pandemic and people not being able to be mobile. It also allows us to do real-time monitoring of disease activity. And as you can see from different tools such as the EDSS and others, we're able to monitor what is happening with a patient over time. If we are able to use sensors, if we are able to use any patient-reported outcomes, all of these could be tracked and trended and used by all the healthcare professionals involved in a patient's care. Adherence is something that we as pharmacists are frequently being concerned about and trying to find new ways to assure that people are, number one, they have their medication, but also that they're taking it effectively. A lot of these medications are injectable, and they have various injection devices. And what we've seen over time is the injection devices have gotten better and better, smarter and smarter, and are now working to assist patients in being adherent and providing that data back and forth to us. So whether that comes via an app, whether there are dashboards that the providers can look at, and whether there's two-way communication from the patient to the provider to the pharmacist, all of these things can be used to help us monitor the patient and provide them with more timely interventions, especially if adherence is an issue. What we also can see is that some patients are able to also gain some access to specialty drugs by providing, or using tools that are available by specialty pharmacies out there to facilitate access. So whether the patient is using the tool or the provider is doing it, there are opportunities on both sides for patients and providers to use these tools and to understand the different medications and to keep up to date on what their insurance plan may cover or what other options there may be for them. So while many of us are using apps, and I for one have a number of apps on my phone, I do know that over time I get app fatigue. I use an app at the very beginning, I get excited about it, I'm very disciplined, and then for whatever reason I get tired of it and I stop using it. I think that this chart shows definitely something that we have to be mindful of whenever we ask a patient to use yet another digital tool, is that there are challenges with that. It's not a simple thing to just open up an app and use it every day for some people. I found in particular, if you look at the chart on the far right, one of the major barriers that patients have is time. People just don't have the time to be using these eHealth solutions, and that's something that we have to understand as we develop them. If we're creating an app, for instance, we have to have it be able to fit into people's lives instead of them having to fit their lives to the app. Another great way that we can help patients lower these barriers is by using care pathways. And care pathways have been around for many, many years. These pathways are important in helping all the people involved in a patient's care work together and understand what the objectives are for the patient. It's creating individualized care plans. It's making sure that communication and collaboration is occurring and that we're working to reduce the challenges that patients have in order to receive the care that they need. A lot of this is started at the very beginning with what evidence-based care is. So scanning the literature, understanding what has changed as new drugs come to market, what challenges patients might have. All of that is important to understand, and as well, clinician buy-in. So if you have pharmacists, nurses, physicians that don't all agree on the care pathway or what the plan will be, the implementation of any care pathway is going to be challenged. Specialty pharmacy's role, we have several specific things that we can do in a care pathway to help the patient. First and foremost is giving any advice that we have on which medications would be best. We see many physicians who are prescribing these disease-modifying therapies now. Most of them are specialists, as Dr. Williams is, but some are more family practice even. And we need to understand that if care is being transferred to family care physicians who may not be as familiar with these medications as a specialist is, the pharmacist has a role that they could come in and play in that aspect. Additionally, providing education, reinforcing education training, assuring that if side effects come up that the patient knows that they are important to report, and to assure that if they run into financial challenges, which we're seeing people have right now during this pandemic, that we're coming up with alternate solutions of funding for patients if it's available for them. All right, so we have another poll. So on your screen, the question is, what barrier to appropriate MS care has the highest potential for improvement from the use of care pathways? Again, this is your opinion, what you think is the most appropriate. So I'll give you all some time to choose, and then we'll reveal the responses. All right, starting to wind down a little bit here. All right, let's reveal the responses. So the majority of you said that from a care pathway perspective, enhancing multidisciplinary collaboration, about 37%. That was quickly followed by reinforcing patient-centered care, and we then are seeing optimizing management and a few others as well ranking up there. So care pathways definitely can be used to enhance MS management. You see from the timeline here, from pre-diagnosis all the way through diagnosis, treatment, and follow-up, that these care pathways and these managements of what we're doing with patients can be utilized. What we also see is that whenever we are using these care pathways, we see that MS care is becoming much more effective. So from a care management versus a usual care perspective, we see that people are receiving their medications more often, that they're having more contact via phone, that we're working and completing assessments, whether those assessments are done verbally, or what we're seeing more and more is that a lot of times our assessments can be simply pushed out to patients periodically digitally for them to complete, and that could come back into the patient record, be trended over time, and then the healthcare professionals, such as pharmacists, can use that in order to intervene or to reinforce what we want patients to know. We've also seen that those that participate in care pathways, we see better adherence, and we also see better persistency, because one of the things that we have to consider is that while people may take their medication or they'll receive their medication, many times we see people falling off the medication and not continuing to take it. Understanding why people do not persist on therapy is as important as understanding why they don't stay adherent to their medication. So when we're looking at, disease management programs and we are monitoring patients, all of these on the left here, MS medication adherence through hospitalizations, all of these can see improvements by working with care pathways and having the patient in an MS care program. One solution does not fit for every person. I know that personally that, for me, something might work, but a person in my family, the same thing that works for me doesn't work for a family member. So it's important to understand that we have different tools, different modalities to use in assessing people with MS. It's not simply using medication possession ratio or proportion of days covered calculations to determine if somebody's adherent. That is one measurement that we can use, and it certainly is an indicator of whether they're adherent, because you can't be adherent, clearly, unless you have the medication on hand. But even if you have the medication on hand, how do we know that the patient's actually taking the medication? So using patient-reported outcomes, coming up with different tools to have them record when they inject the medication, and hopefully in the future, actually, we will know when people inject medication and that it has been actually administered. Those are all things that we want to make sure we are continuing to improve over time so that we could assure that people are getting the benefit of these very costly therapies. What are some of the reasons that people will not adhere to their medication? Well, when we looked at this and you look at this particular study at the VA Medical Center, for instance, you see that people fall off and refilling their medications at least 80% of the time over 2 years. So think about that. How many people do not continue to get their medication? It also contributes to people not going and seeing their doctor. We do know that depression and mood disorders are prevalent in people with MS. And as Dr. Williams explained, whenever you have a neurological disease that affects the brain, the spinal cord, we are seeing that it may be very difficult for people to be adherent, remembering to give the medication, physically being able to give themselves the medication. There could be a number of different reasons. So all of those things have to be taken into account when we consider how people can remain adherent and continue to be persistent on their therapy. So in summary, you could see the 4 bullet points here. Hopefully you were able to see that managing MS is complex. It involves a team of people working with a patient, individualizing the therapy, the care, making sure that we have tools that we could give people to be part of the care that they're receiving, and as well as pharmacists and other healthcare providers, what we can do as they are taking their medications, following up with them and assuring that we can help them achieve greater adherence, persistency, and compliance. So at this time, I am pleased to welcome our next speaker, Alexis Crispino. She will present shared decision-making, aligning MS specialty pharmacy care with patient needs. Alexis is Director of Education and Healthcare Relations at the Multiple Sclerosis Association of America. Please welcome Alexis Crispino.
Thank you so much, Michael. It's wonderful to be here. Thank you, everybody, for having me today. My name is Alexis Crispino. I'm the Director of Education with the Healthcare Relations. And so, let's see. Give me just one moment. So our learning objective is to discuss the strategies to align treatment decision-making with patient preferences and therapeutic goals. So in our patient case once, we have a 40-year-old female diagnosed with MS 7 years ago after experiencing numbness in her legs. The MRI revealed characteristic brain lesions of demyelinating disease. And the current treatment is DMT, and they struggle with adherence. The social history is a single mother of 2 boys, and the current complaint is MS now affects every aspect of her life, and she worries she may no longer be able to support her kids. Apologies. So what are our biggest concerns with this patient? What steps would we take to help improve the overall care of this patient? And where can this patient find the support needed to develop additional self-management skills? So if we look at our patient, we have a 40-year-old female diagnosed with MS 7 years ago after experiencing numbness in her legs. So we want to consider that our opportunity to ensure that they are staying engaged with their care provider, that they are able to overall take care of themselves and their families, and that they're able to find support through MSAA and other programs and services. And so at MSAA, we obviously have the opportunity, I'm so sorry, give me just 1 second. Thanks so much. So then for our next primary challenges for people living with MS. So chronicity, most individuals will live with MS for decades. Unpredictability, each individual experience with MS will be unique, but all will be uncertain. The change MS will require all individuals and their caregivers to make unanticipated changes to their lives to accommodate the disease. And the expense, the appropriate management of disease, its symptoms, and related comorbidities will have a large direct and indirect cost on the patient. Our patient case too. So we have a 35-year-old male seen in a neurology clinic. His diagnosis is laboratory and imaging studies confirm a diagnosis of multiple sclerosis. Family histories, his mother died following a diagnosis from breast cancer. Father had an MI at 59. Comorbidities include diabetes, controlled and on medication, and his current complaints are stumbling gait, diminishing visual acuity, tremors, fatigue, tendency to aspire liquids and solids, continuous tinnitus, decreased finger dexterity, bilateral weakness of the hands, impaired short memory, and irritability. What are our biggest concerns with this patient? What steps would we take to help improve the overall care of this patient? And where can this patient find support needed to develop additional self-management skills? So for providers must foster an ongoing interactive relationships between patients and medical care team, and strive for integration of therapeutics to obtain and maintain disease control, symptom management, and psychological well-being. Patients must be willing to be ready to begin therapy, believe therapy can make a difference, be willing to make a commitment to adherence, and educated regarding the disease and its treatment. In shared decision-making, providers share information with their patients and their caregivers at the center of the team, and patients and caregivers will have time to consider the options. Then together, the provider and patient will make a shared decision. The steps involved in shared decision-making include seek your patient's participation, communicate that choice exists, and encourage your patient to become involved in the conversation. Help your patient explore and compare treatment options. Discuss the benefits and risks of each option. Assess your patient's values and preferences. Take into account what matters most to your patient. Research a decision with your patient. Decide on the best option. And evaluate your patient's decision. Is the decision reasonable? Do you have any concerns? When is shared decision-making most useful? When more than one safe, effective treatment is available, to identify and accommodate patient preferences, and when there is little evidence to favor one choice over another. In summary, management of MS can be complex and requires lifelong care. Treatment of MS should be individualized, and shared decision-making between patients and healthcare providers is critical for successful management and treatment adherence.
Thank you, Alexis, for that enlightening presentation. At this time, we'd like to conduct our faculty idea exchange and question and answer session. So please take a moment, if you haven't already, to submit your questions via the text box on your screen. Feel free to direct your question to a specific faculty member to answer, or I get to choose that person. Please note that due to time constraints, we may not be able to respond to all questions submitted. First one I'm going to ask is for Alexis. So Alexis, I really appreciate the work that the MSAA does. And one thing that I have seen as a pharmacist is, you know, the challenges of people with MS getting their medications covered, getting onto the medication that their doctors prescribe. So what are some recommendations that you have for payers to help address the needs of the MS community that you've seen from your chair?
So I think that, the thing is, when we look at we all as, providers, payers, advocacy group, and most importantly, patients, is we're working towards a common objective. We want to improve health and wellness. We want to improve treatment adherence, and we want to reduce overall long-term healthcare costs. And most importantly, we want to make sure that we're maximizing quality of life outcomes and that individuals living with MS are able to achieve that. And so these things do come at, and although we do have our unanimous desired outcome, it does come at a prohibitive barrier for many individuals. And so whether the issue is cost or geographic location, changes to insurance policies or step therapy requirements that might disrupt this specially curated treatment plan that perhaps a patient and provider have decided on together is the best method, is that it's so incredibly important to continue to have conversations and learning experiences across stakeholders, such as, for example, the payer-provider roundtable that MSA has the partnership, an opportunity to work with Impact Education on, so that we can continue to stay steadfast in improving and creating a system that's more collaborative and can better serve individuals that are living with chronic disease, such as with multiple sclerosis.
Great. Thank you very much for that response. So the next one is for Dr. Williams. Dr. Williams, this is one that we get asked about a lot from a pharmacy perspective. So the question is there any new data regarding the efficacy or lack of efficacy of immune globulin therapy in MS?
Yeah, that's a great question. So IVIG was traditionally used more for, actually it was used as a treatment for MS, and then kind of moved to a treatment more for relapses. So if people had MS activity, or more particular, if people have neuromyelitis optica, which is a disease very similar to MS, but can cause very, very severe disability with relapses. It's been used more for relapses if people are refractory, unable to tolerate steroids, or if they're unresponsive to steroids and just have very severe or devastating symptoms. To my knowledge, there's really not been a lot of buzz about IVIG in terms of any new clinical trials or treatments. It really has been more kind of in that relapse category and not really used as a disease-modifying therapy in recent years.
Very good. Thank you for that response. Next question, I'll take this one. What percentage of patients are using a digital disease app or other monitoring device? That is a great question, and I took the question because I myself don't know the answer, and I think that one of the challenges that we see is the prevalence of data that we know whether somebody is actually using an app or a monitoring device. We could get information on a specific app and the number of people using it or who have downloaded it, but what we typically see is what I presented, which is over time the usage of an app tends to decrease or people stop using them altogether. What I think and what I challenge all of us, including people that I work with, is how do we get digital apps or digital monitoring devices that are passive, that a patient doesn't have to remember to do something. And I think that that's one of the challenges that I'd love to see is, if I were a patient and I had MS, I would want to be monitored as I'm doing my normal day versus having to remember to go and actually do something. Or alternately, have people remind me either via the app that, hey, there's an assessment due. Would you please take this assessment and remind me that way? I think that's one of the challenges that we've not overcome in healthcare is how do we get better adherence to digital device utilization? I think that's a very big challenge for us in this industry. Dr. Williams, I'm going to go back to you, and this sort of builds upon what I asked Alexis, which is, with all the new treatment options that are coming out, with the new drugs coming to market and the ones that we expect to come to market, what's your major pushback that you get from a payer perspective? What are you seeing, and what are some strategies that you have utilized in order to work with payers to get these treatment options covered for the patients?
Absolutely. So to Alexis's point, one of the biggest obstacles can be step edits, and certainly we know that in many cases they are appropriate. I think that one of the difficulties is that, in recent years with some of our newer therapies, there have been step edits that were a little bit difficult to clinically, I won't say justify, but for instance, with one of our infusion therapies, I remember one particular one where a patient had to have been on an interferon before they went on this particular therapy, which was more likely when it came on the market like a second or third line. So we had to do a lot of letters and things like that. I think one of the things that's been very helpful is that many of us in the MS community kind of band together. We have listservs, things like that. If there are approval letters, we often kind of do those, but sometimes it can be very time consuming and keep patients off of effective therapy. I think also, with different classes, as we have more drugs in different classes, it may be difficult to have certain medications approved that may be easier for the patient to take. Let's say, for instance, with our S1P inhibitors, there are some that require monitoring versus some that don't. So depending on how those are priced, someone may have to do extra monitoring and work to get on a therapy, whereas there may be another one with less hassle, so to speak. So, certainly many of us are trying to help each other, certainly being respectful of our colleagues in the pharmacy field, knowing that there's work for all of us to do, but making sure we're writing those letters and trying to get the best care for our patients possible.
Thank you very much, Dr. Williams. Alexis, I'm going to go back to you for a question, and this is, about your organization, the MSAA. So from, your perspective, when you are working with the MS community and working with patients specifically, what are some of the primary resources or services that MSAA is providing that patients find to be, the most helpful or the most vital and have the biggest impact on their lives?
Thank you. Yeah, so at MSAA, we have the opportunity to connect with more than 100,000 individuals living with MS and their care partners on an annual basis. And this could be through our patient education programs that feature an expert in MS care like Dr. Williams, nationwide, just providing patient education in different cities. We have our daily living aid equipment program, which is going to extend things like canes and shower grab bars to individuals. We also have our cooling equipment program, which is going to help address individuals that might be experiencing heat sensitivity. But I'd say among our most in-demand programs, especially for individuals who are experiencing financial challenges or are underinsured or uninsured, it would have to be our MRI Access program. So eligibility for this is based on a household income falling at or below 300% the national poverty line. So for a family of four, that's about $79,000. And through the MRI Access program, an individual who's newly diagnosed or going to be newly diagnosed or for disease tracking can receive a C-spine or cranial or both MRIs. And MSA can connect with one of our contracted imaging centers to have the individual go directly there. Or MSAA can pay back the insurance company up to $600 to cover the cost of the copay or co-insurance for them to be able to get this MRI.
That's great. Thank you very much for that. And with your mention of MRI, I'm going to go to this question for you, Dr. Williams, and then I'll have a follow-up question as well. Given the non-specificity of symptoms of MS, at what point should primary care physicians order an MRI to rule in or rule out MS?
Absolutely. So that's a great question. Generally, if someone has neurologic symptoms that are concerning for MS, and often MS symptoms are mistaken for symptoms of stroke, but many of our patients may have numbness and tingling, other symptoms that are common to other diseases. I honestly usually recommend that a person be referred to a neurologist if at all possible. But if someone is being seen by primary care and they have concern about, symptoms of numbness on one side of the body or numbness in one leg that hasn't improved in a young, healthy person, then that may precipitate some imaging. But I usually do try to defer that to having someone assessed by a neurologist, at least a general neurologist if possible.
Thank you. These next two questions are sort of linked, so I'll ask them together and
Sure.
for your response, Dr. Williams. So the first one is higher disease activity at baseline a reason why a provider may choose a higher efficacy DMT as initial therapy? And then the next question is, based on data from second and third line agents, will they ever become first line agents due to efficacy? So I thought those two were good questions to link together here.
Absolutely. So to the first question, absolutely. So when we look at those prognostic factors, if a person has, let's say, a very severe relapse where they may have poor recovery, plus they have an MRI with multiple lesions in the brain and they have multiple lesions in the spine at onset of diagnosis, those are pretty poor, that indicates that they may have a more severe course of disease. So those are people that will be very likely to be started on a very higher efficacy therapy to try to prevent disability in the long term. In terms of the second question, for most of us who specialize in treating MS, at some point, most of us have wanted to put a patient on all therapies first line. So even the ones that are second and third line, many of us have encountered a patient who would be appropriate to have that therapy as a first line therapy. I think that one of the difficulties and reasons that much of the paradigm is shifting in terms of earlier, more effective treatment is because essentially we were waiting for something to happen to someone to put them on a more effective therapy. So the goal is to start early, treat effectively, and be quick to escalate if they have problems.
Thank you very much for those answers. I appreciate you taking the two questions at once there. You did a great job. So I apologize. We have more questions than we have time for answers. So thank you all who submitted your questions. Apologies that we cannot get them all covered here. I would now like to conclude, though, this webcast and absolutely thank both Dr. Williams and Alexis for their excellent presentations, your insightful commentary as well. Once again, I'd like to thank Sanofi Genzyme and Bristol Myers Squibb for supporting this educational activity. I'll now turn the webcast over to our operator, who will provide important information regarding receiving your credit. Thank you and enjoy the rest of your day.